I am the Associate Medical Director for Cardiovascular Intensive Care Services. I'm also the Medical Director for the Center of Analytics and Clinical Effectiveness.
I'm Claudia Albace. I'm a pediatric cardiologist and Associate Director of our Clinical Effectiveness Program.
Share our experience and journey with clinical effectiveness, and we're very privileged to be speaking on behalf of HIMSS and the organization. The local problem that we started with is the fact that Lucile Packard Children's Hospital at Stanford Children's Health is unique in the sense of the number and volume of complex patients that we have. This is a data graph that shows from the Pediatric Health Information System database that the case mix complexity of Packard tends to oscillate between the number 1 and number 2 position. So our case mix index tends to exceed that of many other children's hospitals. Not just with the care of children, but the efficiency of the care of children, specifically when it comes to capacity issues, when it comes to length of stay, and the problem of that, coupled with the fact that care in general is being driven from volume to value-driven healthcare, is becoming a salient point here at Stanford. The clinical effectiveness program is really focused on seeing if informatics and the use of the information within the electronic health record can help with the transition from volume-driven healthcare to that of value-driven healthcare. Also one of national problem where there is well-documentation of massive variations in clinical practice, which leads to a high rate of inappropriate care. There's also well-documented reports that there are unacceptable rates of preventable care-associated patient injury and death, and also the striking inability to do what we know works, specifically when it comes to clinical practice guidelines, when it comes to checklists, and other pathways. All of this culminates to a significant amount of waste, leading to rising prices that ultimately limit access to healthcare. Care unit for a child who's recovering from congenital heart surgery, and you can see the degree and amount of technology that is needed and necessary for the support of this patient. As you can see, and as we've all experienced, the amount of technology and the amount of data generated from that technology is really outstripping our pace to really understand and cognitively process all of that data. But for us, we think that this might actually be an opportunity to see if we can leverage the information and the data that's being generated from the electronic health record into a way so that we can gain a little bit more situational awareness of our practice. So the Clinical Effectiveness Program here at Packard is a program that is really grounded in learning the most effective and sustainable models to reduce unnecessary variation while maintaining and improving outcomes for our patients. We have a preoccupation with value, specifically in our healthcare system, mostly for the patients and families, but we're also very sensitive to the organization and maintaining organizational health. And we want to do this with a data-driven and a data-transparent approach. We'd like to supplement existing organizational process improvements as well as quality improvement infrastructure within the hospital, and really not replace it, but instead be able to complement our activities with those of quality improvement. How is just as important as how we ultimately implemented our program. The governance body of clinical effectiveness is the body that really determines the priorities and the resources for the program's ultimate growth, scalability, and sustainability. This governance body is represented by shareholders when it comes to executive leadership and administrative leadership, and we report out to the performance improvement body within the organization as well as the quality improvement body within the organization. That also includes the board of directors. The governance interfaces closely with the core group, which is basically the brain trust or the thought leaders within clinical effectiveness. And here is where we ultimately plan and develop and implement many of our initiatives. We measure outcomes here, and we measure processes and balancing metrics, as well as iteratively improve upon our program. The core team interfaces with the existing infrastructure when it comes to quality improvement, and that's the use of microsystems or local improvement teams. These local improvement teams represent the units, in which case which further represents the interface between the patient and the providers. The microsystems provide critical feedback to us, as well as being able to monitor and audit our work. Here, as a representative of a big team representing clinical effectiveness, that again is a multidisciplinary perspective, representing nursing to informatics to physicians and surgeons, as well as analytics and informatics. Our focuses on a problem that the hospital is very sensitive to, and that is the fact that Lucile Packard Children's Hospital tends to run near or at capacity nearly all of the time. There's also a significant amount of variation in care. As a result, there's also variation in our outcomes. And ultimately, that culminates into suboptimal value. We tend to be costly, and we don't have the high quality to really account for that cost. So our goals immediately, within the first 2 years of our program, was to reduce the unnecessary length of stay for our elective surgical cases. And we strategically focused on the Heart Center as the pilot division, given the Heart Center's cultural readiness for improvement work. Our primarily was the duration of mechanical ventilation following surgery, the number of intensive care days, and the total hospital days as well. Our secondary metrics included the total hospital cost as well as family satisfaction, and we have a preoccupation with safety here, and we wanted to really focus on reintubations and readmissions to the ICU within 48 hours, as well as 30-day readmission rates to the hospital. Initially on the Division of Cardiology, specifically because of cultural readiness, but there is a case from a cost perspective as well, as congenital heart disease accounts for approximately $6 billion in annual hospital costs, and compared with other birth defects, congenital heart disease are often associated with some of the highest hospital costs and charges, some of the longest hospital stays, as well as some of the highest mortality rates reported. When we started, we wanted to focus on pathways, which I'm sure is familiar with many of you, but a pathway is a very prescribed way of trying to standardize care through processes that have been agreed upon and that really restrict or limit providers' ability to deviate from what we consider to be best care practices. We found the pathways initially to be quite cumbersome in the sense that the planning tended to be very involved and very laborious. There tended to be a significant amount of consensus building, analysis of the problems. We needed to determine the drivers within our specific hospital. We oftentimes had to work without the use of evidence to guide us, and also there was the lack of benchmarks to be able to guide the building of any particular pathway. And then the implementation phase tended to require a lot of heavy lifting as well, to try to tailor it to the local environment, to train, to communicate, to coordinate, and ultimately to implement, review, and audit and obtain feedback. So there tended to be a significant amount of investment of time and resources and energy, and ultimately that led to unknown benefit for that particular cohort of patients. There oftentimes are cultural challenges, as the pathways are, again, consensus built based on experts, but the experts tended to be very varied and heterogeneous, and oftentimes not necessarily in sync. So we did differently, not only just in terms of how to develop a pathway, but also how to ultimately improve and sustain and scale improvement work that was a little bit more user-friendly for frontline providers. And we came with a novel program which we call target-based care, which is the transparency of outcomes from comparative aggregate patient data to be delivered at the point of care to synchronize healthcare delivery. And that's a mouthful, and ultimately what we really wanted to do was see if we can utilize information to be meaningfully useful for providers, and also to be able to use the data to develop and establish benchmarks where benchmarks are oftentimes unavailable. This was a report that tended to be a central point for our program development. And this report really described the need for having benchmarks, specifically achievable benchmarks, to really guide care in the efforts to standardize care. So one of the fundamental reasons why providers do not follow clinical practice guidelines or pathways is really the fact that there is a lack of a transparent, achievable benchmark of care. And I can give you a specific case example. And the example is that there are numerous care pathways and CPGs that recommend against the use of chest x-rays for pediatric patients presenting with asthma exacerbation. However, in reality, chest x-rays are taken in 46% of these cases, which is a potentially unnecessary cost. So this really drives kind of a central clinical tension, because striving for 0% chest x-ray utilization will likely mean missing important diagnoses such as pneumothorax or pneumonias, and I'm sure there are many emergency room physicians who can recount how a chest x-ray was meaningfully important. But on the other hand, we really shouldn't ignore evidence-based practice or best care practices that recommend against the use of chest x-rays. So the question remains, what is the benchmark, or what are the goals that we should strive for in developing these quality metrics? How is it suboptimal? And this, again, is one of the principles of how we developed our program. But every patient encounter that leads to an outcome generates data and information. And how that data is generated has oftentimes variable penetrance when it comes to the healthcare providers and how they digest that information. And then when the next patient encounter comes, it's quite variable in terms of who would potentially have learned from the previous patient encounter that might impact the next patient encounter in a meaningful way. And I think the variability of healthcare tends to perpetuate itself given how we don't standardize how we learn. And so the target-based care program really focuses on utilizing the electronic health record to generate an aggregate experience. And that aggregate experience then guides the physician providers and the nursing providers at the bedside for that next patient encounter. This was an important learning point for us, is when we polled several physician providers and nursing providers what the anticipated length of stay is for a given particular operation. The answers were all disparate. So everyone was operating with a different mental model, and having that different mental model meant that their practices would likely reflect a different level of cadence of recovery for that patient. So utilizing aggregate patient data to really synchronize the mental model by having transparent benchmarks would potentially help standardize the care by having everyone on the same page when it came to the healthcare goals. So how we played this out was we took a candidate operation and we developed historical cohorts developed from the EHR. And this historical cohort spanned back approximately 2 years worth of data. And here's a representation of how the outcomes for that particular surgical cohort varied in terms of its outcomes. In this particular case, this was length of stay. Our hypothesis was that if we picked a target that reflected that experience, and in this case we picked the median length of stay, we hypothesized that the care would become more centralized towards that target and variability would decrease. And potentially, if there was waste in the system, that outcomes would improve as providers gained situational awareness of what was achievable and what was possible. So this became the third arm of our intervention, where we set benchmark targets were displayed at the point of care for that patient coming through that system. And so these were, again, represented schematically here, a candidate operation. We developed aggregate patient data for ventilator days, for intensive care days, as well as hospital duration. And we made that transparent to the frontline providers, and we set goal extubation times based on that aggregate experience. We set goal transfer dates, and we set goal hospital discharge dates based on that aggregate experience, and we made that transparent to the frontline providers, and that is represented by this photo here. This is a patient that has recovered from surgery and is now spending his first day in the ICU, and we can see that the targets are established here and were made available, not just at the moment of the ICU, but when they first walked into the hospital. And you can see that there is a specific time to extubate, there's a specific date to transfer by, and a specific date to discharge the patient by. This was to point out that this was not only transparent to the providers and the nurses, but also transparent to the families who were at the bedside as well, which was kind of an interesting experience for us. But what we found was that families oftentimes were the recipients of different information altogether when they first walked into the hospital. Their referring providers oftentimes gave them a very different answer to an expected length of stay that was different and disparate from what the healthcare providers in the hospitals were anticipating. And so this moment where the goals were established at the point of care was an opportunity to level set expectations for all stakeholders.
Results with you. We've had over 106 cases scheduled for surgery, the majority of which patients were enrolled and completed our clinical effectiveness program. To include some representative outcomes, this is one particular surgery called tetralogy of Fallot and valve-sparing repair for this surgery. You can see that we've not only made impact in our time to extubation and post-operative ICU length of stay and total length of stay, but we've significantly decreased the variability in our care. This is an example of a more complicated surgery for tetralogy of Fallot called the transannular patch, and you can see we've made similar impacts both in reduction of length of stay and time to extubation, as well as the variability. Similar results for a more common congenital heart defect, ventricular septal defect. Again, we've showed significant reduction in length of stay and variability. So, all different surgeries, and we've really been able to leverage our electronic health record to identify eligible patients and enroll them and apply our clinical effectiveness program. We've really length of stay reduced from our target length of stay, and this is translated into improved hospital opportunities. So when you consider how many surgeries are done for these particular surgeries per year, we estimate an annualized hospital opportunities listed here, and the ones that appear in red are statistically significant. So overall, we have 34% reduction in our length of stay and have created almost 300 hospital days, and this translates to an estimated cost savings of about $2.5 million per year. Internally, but how we compare to similar high-volume centers. So we used some benchmarking data from the Society of Thoracic Surgeons, and we noted that while we were already doing pretty good compared to the median length of stay compared to these centers, our post-intervention data suggests that we're doing even better, as you can see in red. In organizations focus on family-centered care, we really paid attention to family satisfaction both during their hospitalization and through a standard 7-day post-discharge call. And we were really excited to see that our results were quite favorable, in particular that the majority of patients felt ready to leave the hospital upon discharge. balancing metrics, as Andy suggested, we're very worried about safety and wanted to make sure that in an attempt to get patients out of the hospital more efficiently, we weren't impacting that safety. We looked at reintubation rates, readmission to the CVICU rates, and 30-day readmission rates, and we're thankful for the favorable results. These rates are low across the board. Impact on the example by facilitating patients to get out of the hospital in a more efficient fashion, were we actually utilizing more resources. We did find that for a variety of different surgeries, we actually found the opposite, that our cost per surgery after our intervention was actually lower, and we're in the process of looking at that in a statistically meaningful fashion. But overall, we have leveraged our electronic health record at the point of care to provide target hospital goals, and have found that it's associated with improved outcomes, family satisfaction, and improved institutional costs.
In terms of how we proceed with the program and how we continue to integrate with the electronic health record, these are some examples of how integrating with EHR for clinical effectiveness continues to hardwire the EMR so that it makes workflow a lot easier for the providers to follow. This is an example of how we can flag or tag patients into the clinical effectiveness program simply by writing an order that identifies the surgery that they're undergoing, and this allows us to retroactively go back and to be able to analyze the patients in the program much more efficiently. We also have been able to build specific triggers that are triggered by the surgery, and by doing so, we can help the providers at the front line with identifying protocols or order sets or even information, so that they can have the information, the relevant information at their fingertips. And here's an example of an order set that we built for a tetralogy of flow surgery that, again, guides them through what the best care practices are within our program. And finally, this is one of the web resources that we have. This is a link from our electronic health record that shows, the last link, which shows clinical pathways, by simply at the interface of production, where the providers are writing orders, they have access to all of our documents and resources related to clinical effectiveness through this clinical pathway button that takes them to the central repository. And probably most exciting and interesting for us is the ability to transform how we ultimately develop a pathway. Whereas previously, providers develop pathways based on a consensus-based approach, here we may be able to augment that by really identifying the successes and the failures. By taking patients who have successfully met the targets and comparing those patients who did not meet the targets, could we identify best care practices that are unique to successful patients, so that care pathways and protocols can be more data-driven as opposed to relying on content experts, which are oftentimes varied in opinion. At this point in our program, we are at the point of scaling. We have taken the program out of the Division of Congenital Heart Disease and have moved on to solid organ transplantation, neurosurgery, as well as orthopedic surgery. These particular operations that we've identified have been flagged because of not just the volume of surgeries that we see here at Stanford Children's Health, but also the variability in their outcomes as determined by our analytics. And not just from our institution, but also branching out to our potential partners in joint ventures and existing partners in joint ventures to be able to expand the program and demonstrate the generalizability of the concept of just establishing aggregate patient data-derived benchmarks to really guide clinicians to standardize their care by working towards a common hospital goal. synchronized healthcare delivery system that is guided by an aggregate experience, we believe is a step towards a continuous learning system. What we describe as having an aggregate experience be transparent to the providers and utilizing that aggregate experience to ultimately derive and develop a benchmark for providers that be more informed and gain situational awareness of what's possible. And by having a more informed practice, what we've been able to demonstrate in our use case here is that outcomes do improve and variations do improve as well, which ultimately impacts the aggregate experience. And so we have this continuous loop where the aggregate experience continuously improves, which then, as that becomes more transparent to providers over time, also drives the targets to become much more meaningful and much more reflective of what is possibly the best care practice. So we struggle with the fact that there isn't really much evidence-based medicine to guide us, and we hope this is an example of transforming that concept into what is a practice-based evidence. An learning healthcare system really does call upon the EHR data and to utilize the EHR data beyond their original purpose of supporting the healthcare of individual patients, which can ultimately speed the progression of knowledge. And we hope to demonstrate that use case here where we're able to then take the EHR out of the production system, transform it into information that's available to providers at the point of care to guide their therapies. And probably most salient to us is this note that was sent by a parent whose child was enrolled in the target care program. This parent gave us a poem, and this poem is called The Lacking Factor by Ambrose Pierce. It starts off, "You acted unwisely, I cried, as you can see by the outcome. He calmly eyed me. When choosing the course of action, said he, I had not the outcome to guide me." This parent went ahead and wrote to us that the physicians and nurses caring for my son was guided by the outcomes of the many patients before him, and we are grateful. HIMSS group for being able to have the opportunity to share our experience.
And thank you, Dr. Shen and Dr.